everybody. Today we are going to talk about the sacroiliac joint. One of the most important thing in the sacroiliac joint is, as you just mentioned, is that people think they don't see it. They think is it even real? Is it the made-up diagnosis and so on? And the story behind that is actually very interesting. We start doing sacroiliac joint long time before we start doing spinal fusions. Just the surgery was so devastating, so massive. Once we start doing spinal fusions in 1950s, we sort of, for almost 50 years, we neglected sacroiliac joint. We didn't do research on that. We just did it in combination with other surgery, spinal fusion, or in trauma. So it was truly an orphan child, it's a Cinderella of kind of joint. We neglected that for a long time. And the story behind that is that when we start doing that, medial to lateral, meaning going from the medial, taking all the ligaments off and going to the sacroiliac joint, it caused so much damage that the surgery almost was worse than the disease itself. So the results weren't good. And everybody who tried that didn't have good results, so it didn't really catch up. And that makes sense. If you look at the sacroiliac joint, it is a joint that we call it a joint. It's not a real joint. It doesn't really have any significant motion, and it's stabilized with lots of ligaments. And going from medial to lateral, you have to go through those heavy, massive ligaments, and that actually destabilizes it. And it is a flaw actually in the design. The human, we are standing up. We are suspended, or 2/3 of our body weight, or torso and above, is suspended on the sacroiliac joint. And for lots of animals that they walk on fours, that is not as big of a deal as for human. So I'm just reading a book. It's called the Practically Flaws of the Evolution, and that is one of the things that evolution just in the last 100,000 years or last 500,000 years taught us how to go on two, but our sacroiliac joint is truly not ready for that. Now, this is a solid statistic. This was done again and again. The numbers are around this. So if somebody comes to a private practitioner, family practitioner and general practitioner with lower back pain, 22% of that is not lower back. It's not the spine, it's a sacroiliac joint, okay? If you had a previous fusion in the lumbar spine, that number jumps up to 43%. So what that means that if you are not diagnosing almost 1/4 of your initial back pain patient with the sacroiliac joint, you're not really diagnosing them according to the statistic. And the fact is that since I'm doing sacroiliac joint fusions, my number of my so-called failed back syndrome, and tell me, you understand what failed back syndrome is for our audience. Tell us, what is the failed back syndrome?
As I understand it, it's when we've seen it, it's when they undergo procedures, numerous procedures a lot of times, and the pain never gets better.
Yeah, and so you see that the 43% of the people who have lower back fusion, when they come back with the back pain, the problem is not spine anymore, it's the problem is sacroiliac joint. And if you don't look into that, if you are not trained to see it and understand and diagnose it, you're not going to diagnose them. You look at their spine, you tell them everything is fine, it's all in your head, get out of here. And those are the patients who come to me. I do a 15-minute procedure. They stand up and hug me because for years they are told there's nothing wrong with them. And I see that. These are the most appreciative patients because they are told there's nothing wrong with them. And they say, I had a patient who was saying, I didn't want to live anymore because I thought I am crazy. This is, for me, is real, but nobody can help me. I'm a burden, and they go to doctors with their family, and then the doctor said nothing wrong. The family believes it's nothing wrong. It's in their head. They're just trying to get out of, they're participating in their life and so on. The family break. This is a big deal, and it's not a little. Mm-hmm. How many spinal fusions are performed in the United States in 2021? You want to guess? Give me a number. Anybody?
500,000.
1.62 million spinal fusions are performed in 2021 in the United States. So imagine many of them end up here because sacroiliac joint at the end of the day is the adjacent segment to L5S1. Okay. Now, and again, this is there are different the papers, different statistics. They show again and again very similar results that it's a big source of lower back pain. Okay. Now, I'm not going to go through lots of didactic here, but it's at the end of the day, it's about, is the sacroiliac joint the pain generator? We have solved that problem for other areas, like for the facet, for medial branch, for spine. We have methods to decide if that area specifically is a pain generator. And most of that, when we come to the diagnostic, we talk about that. But let's actually.
Can I ask you a question, Dr.
Absolutely,
Bassi?
absolutely.
So one thing that we've noticed that our colleague has taught us about this, which I did not know, is that a lot of these patients will present with radicular symptoms as well.
Mm-hmm.
And
Good
it fools you.
Good one.
Because you go, it's going down the leg. Why? Why is this? Your back looks normal.
Yeah, absolutely. Good point. Now, there is a reason among people who do sacroiliac joint, we call it chameleon joint, because it can pretend to be a pelvic stuff, hip stuff, the lumbar stuff, and that is the exact reason we call it sacroiliac joint. We call it chameleon joint. It can pretend to be other things, and when we get to that, and I show you why you are going to have, is normal to have radiculopathy, and what radiculopathy is more common than the others in the sacroiliac joint. And that is for 30, 40 years, that exactly was the understanding. How would it cause radiculopathy? So if you have radiculopathy, there's no reason for sacroiliac joint cause radiculopathy. And then we would look at the spine, there's nothing wrong there.
Really no. Yeah.
Then you're faking it, or you are not real, or it's in your head, and so on and so forth. So this is the anatomy. Now, who can tell me here what is the only muscle in our body that goes from one side of the sacroiliac joint to the other one? What is the name of the muscle that goes? Then we have like here. You can tell me muscle that go from one side of the elbow to the other side, act on elbow per se.
The iliacus muscle.
Well, give me the name of the only muscle that works on the sacroiliac joint alone. It's made to move the sacroiliac joint. There is none. There is no muscle. There's not a single muscle that works on the sacroiliac joint. There are muscles like iliopsoas goes from the spine to where?
Down the leg.
To the legs. Yeah. So it crosses. There are lots of muscles that cross the sacroiliac joint, but there is not a single muscle in our body. Our body has eliminated every single muscle that works on the sacroiliac joint has been eliminated. What does that tell us? That this joint doesn't have a physiologic motion. As a matter of fact, the only time when it moves is during the birth process, like an open book, to give baby a little more space through the pelvic floor during the birth process. As a matter of fact, all the studies show that if the motion is more than 4%, 4% is like from here to here. This is 4%. Okay.
Yeah.
If it's more than that, it's actually pathologic. So that tells you that this is not a true joint. Now, here, that is, we look at that very carefully because that's a very important picture to show you the nerves that pass over sacroiliac joint. You see L4, L5, S1, but L3 comes very close as well. So now we know it from other joints like hip joint and knee joint that when the joint is inflamed, the nerve surrounding can be as well inflamed and can give you nerve symptoms from those nerves. So does it make sense that before the lumbar sacral plexus come together, become sciatic nerve, that individual nerve can be irritated and give you radiculopathy? That has been truly, we come back to that. The studies are done. The joint, have you looked at the joint at the sacroiliac joint itself? This is how it looks like. And this is a normal sacroiliac joint. this, something looking like that in any other joint would be very, very pathologic. Like how I had the opportunity to scrub it with the orthopedic surgeon, and I had the femur of a 70-year-old man in my hand. I took a picture of it. It's the smoothest thing you can see.
Yeah.
Smooth, I mean, unbelievable. Like, you know, like you have a smoothest ball in your hand. But this is a normal sacroiliac joint. Why? Because it's not a true joint. It's a synostosis. Is that something that, you know, evolution hasn't caught up yet, that we don't really need that, and hasn't grown it together. Come another 100,000 years, and this will be no joint. It will be just bone, like our skull growing together. And there are two parts to that. Let's go back here. It's called a ligamental part of the joint, and then there is the so-called articular part of the joint. It is a very complex joint. One of the beauty of the evolution is that if you don't really need that, it's going to be lots of variation of it. And those variations are not functional, so everybody has equal chance of surviving it. So sacroiliac joint is one of the joints with the most variability. Even in one person, one side can look different from the other side. The angle of it, the approach of it, all of that is extremely different in every person. So that makes it actually a little harder, even for injection. Like, you know, you have to maneuver almost between the bone pieces of bones to get the true sacroiliac joint injection. But there are methods to do that. But that is important to know, that it is very variable. It's not a real joint. And the normal sacroiliac joint look like an extremely pathologic joint anywhere else in our body. Now, it is important, this is important, take a mental picture of it, because injecting sacroiliac joint, when they come to that, is not a trivial thing. You have to be in articular part of the joint, you have to do it in a certain way for that to be diagnostic. Otherwise, you're just going to inject it in vicinity, get a false negative because you weren't in the joint, or get a false positive because you're just, you're doing it next to the nerves there. If you put it next to the nerve there, then no matter where the pain is coming from, you're not going to get any pain. So we come back to that, but take a mental picture of this because this is important. Now, we talked about the ligamental, how it's suspended with the ligaments. Our whole torso is suspended there. That is, take another mental picture of that, because that is why the medial to lateral is dead. I mean, you have to go through all that thing. You have to destabilize it to stabilize it. Whereas in the lateral to medial, which we come to that, you don't have to do any of that. Let's talk a little about the anatomy and x-rays that we are going to see in the lab in about an hour or so. Obviously, it's very important for you to see the true lateral. And you remember we talked about every person is different. Even in one person, one side and the other can be different. So there are landmarks that you cannot miss. Like, obviously, you cannot miss the greater sciatic notch. It's hard to miss that. Well, I take it back. If you know, if you have lots of gas, like, you know, some surgeons do bowel prep for this. I don't, because I mean, I show you my technique in the ward to see still, even with lots of gas, to see this greater sciatic notch. Here, this is the greater sciatic notch, and on both sides you see two shadows because you have two of that, and you have to align them. That's important. Another important factor is ala of the sacrum. So, and sometimes it's hard to align them both. You align for this goes out of, you have a parallax for that, and vice versa. Yeah, and then you have to just make a decision and, you know, find a place between them. Okay, but then what you see, obviously, you see the disc, you see the promontorium. So remember these names, okay? Greater sciatic notch, ala, promontorium, which is here, the top of the sacrum there. And the disc, not really necessary to know that and so on. But these three structures, greater sciatic notch, promontorium, ala, are important. Obviously, you see the sacrum. Now, another thing with the sacrum is that we know that is a 5 to 7 fused segments, right? Just the 3 first segments, S1, S2, S3 is important for the procedure because that's where you put the bulk of the metal in. Okay, so disregard anything beyond S3. And in a real person, the segments are not that visible. You see that, you see barely the remnant of S1, S2, S3. Maybe if you are very imaginative, you see S1, S2 here, right where the thing is. But
Do you ever have a problem when there's transitional anatomy?
Well, I
Does it ever-
don't because I decide which chunk of bone I'm going to put my screws in, and that I aim for
Stick with
that.
it.
Yeah, I just because at the end of the day, you want to fuse the ilium to sacrum where they connect together. What they are called, if it's S2, S3, S4, is the same as if it's called these numbers. We just made them up. Okay, so the nature doesn't care. One bone is connected to other. You have to identify that chunk of bone that are connected together and stabilize them by putting screws across. That is more of importance if you do lumbar surgery, the transitional, because then sometimes, the nerves that go where you expect it to be L5, it's actually S1, and then you get a discrepancy in your exam, and then in the OR, you have to decide, this is the S1, L5, and so on and so forth. For here, you see what connect them to each other, and don't even bother. Just go through the mass of the bone that are connected. You go through the articular part of the sacroiliac joint, mostly articular and ligamental. You go through that piece, and whatever those bones are, it's really not relevant to what numbers they are. So let's talk about the so-called inlet view. Okay, sacrum is the only bone in our body that we can get true axial view of the sacrum, and that makes sense because it comes up. The rest of our body, you cannot really get an axial X-ray, right? You can get AP or lateral, but not an axial. But sacrum, you can get a true axial view of the sacrum by bringing the camera looking into the buttock. And if you want to remember that, the way to remember that in medicine, always add a little dirtiness to it, then you remember it. The inlet view is into the butt. Okay, that's the inlet view. An outlet view is not 90 degrees to the other side because sacrum is a wedge. It's 65 to 75 degrees to the other side. Okay, so, and the outlet view is a true AP view of the sacrum, and inlet view is a true axial view of the sacrum. And here, that's what you see. And you remember we said, pay attention to S1, S2, S3, where the bulk is. Sometimes sacrum is not truly like a wedge, it's like a curve. Okay, so, and if you try to align everything in axial view, you will fail. But if you disregard the 4, 5, and so on, but I just concentrated on S1, 2, 3, you see 3 ridges, actually 3 ridges when you do your fluoro, and then you come until you literally, the 3 become 1. Almost sound like a religious mantra, 3 become 1. Like S1, S2, S3, you see 3 ridges, and then when you adjust it properly, the perfect view is when you get truly this line here. You see 3 lines here, they become 1. Imaging is extremely important in the sacroiliac. Once you have the right imaging, the surgery does itself. You're just standing there and just you're a bystander. That's extremely important. So in the lateral view, we choose the entry point. I come back to that, okay? But the entry point at the end of the day is, depending on what you do, there are multiple ways of doing surgery. In our surgery, the entry point is actually just anterior to the border of the sacrum, because when you put your guide wire there, you're on the iliac crest. You have to pass the iliac crest. So you have to start out here in the so-called, what we call perpendicular to the sacroiliac joint. You start the entry point right here. If you are going to do true lateral to medial, meaning you don't care about this joint itself, you just want to go across, then obviously you start it within the confine. But in this surgery, which is truly perpendicular to the sacroiliac joint, we go practicing lab, you start the entry point anterior to the border of the sacrum here. But let's go back here. Now here, the aim should be the mass center of S1, obviously. Okay, so you remember that. Entry point in the lateral view, and that's all what you use the lateral view for, is anterior, just barely anterior to the border of the S1. The aim, the target in the inlet view is the center of the sacroiliac joint. Now we have another thing here, the so-called outlet view. The outlet view is the true AP view of the sacrum. And that is obviously the view that you see the S1, if you're lucky, S2. It's much harder in the surgery, especially if you don't do bowel prep, because there's so much air in the rectum and so on and so forth, that it makes it harder to view. But then, preferably, if you're going to do whatever technique you use, you're going to go, most of the time, put one of the screws in the S1. You put 2 or 3 screws, because if you put only one screw, it still can rotate around the first screw. The second and the third screw is just to prevent the rotation. And the mass of the screws are in S1, S2, S3. And that is, so in our surgery, I'm literally aiming for S1, S2 foramen. And you see why. When we are doing that, the angulation works as such that that's the best place to aim for. One of the other things I do always, I'm only 40% of the people who do sacroiliac do that. I always get neuromonitoring. For that reason, I'm doing neuromonitoring. If I'm getting too close to S1 foramen, I know it, so I can be more aggressive because I have a backup. So if you see my screws, they're just 2 millimeters into the bone of the S1 foramen, but not really causing any problem because I know, and then I back it up. If you don't have that, you're usually more careful. You lose stability because you're not as aggressive to put bigger screws or deeper screws. So, but neuromonitoring allows me to utilize more of the anatomy for this surgery. So, and let's talk about that. The reason now lateral to medials are now the standard of care is most of the anatomy, what really matters is inside of the pelvis, outside of the pelvis, and they are safe as long as you don't put a 9-centimeter screws that goes all the way across. And one of the things we are going to talk about in the OR, in our lab, is that work your way up. When the patient is laying down, then give me that thing, please. Let me show you one in the surgery. In the surgery, look at that here. Patient is laying like this, right? You never want to work down because working down takes you to the pelvis. You want to work up because that takes you to here. Extreme rare cases, even if you come out here, it is not as problematic than if you come down here, because here are the nerves, major vessels, and so on, bowel, and so on here. But you tolerate a lot more. Even if you extrude out here, you have S1, S2, S3, barely the sensory, the roots that coming out there. It's not a big problem. Now, I haven't been in here or out there for any reason.
Is that why you start on that, just anterior to the sacral, to the sacrum? Is that why you start down that way?
See, this is sacrum, and this is the ala, right there. You see that there?
Mm-hmm.
So when you're getting the X-ray, you see the shadow of the sacrum in the X-ray. Mm-hmm. When you go in, you have to first hit the iliac crest. Yeah. And again, there are 2 ways of doing this surgery. Truly lateral to medial, then you are at the angle to the sacroiliac joint. Or there is so-called true perpendicular to the joint, which for that to be perpendicular to the joint, you have to be at an angle to the patient because sacroiliac joint is not,
not
straight in the inside of your body. And to do that, you have to go at this kind of angle. And this angle, you have to start on the anterior shadow of the sacrum, because by the time you pass through the iliac crest, then you will be centered on the sacroiliac joint. So let's just continue showing that. Now, you have to be conscious about one thing when you're doing the surgery, and I injured it only once, okay? And that is the supragluteal artery. Inside, you see that there? All the vessel, outside, only this one. And most of the time, it's not a problem. No, most of the time. 99% of the time, 99.9% of the time, it's not really a problem. It's not even in your way. But when it is in your way, the way I deal with that is when I use a guide wire, I use the dull end of the guide wire. See here, look at that here. That gluteal artery is coming about here, going this way, right? Mm-hmm. I go through the skin with the dull. I keep it there on the bone. Then come over, please. Run it over for you. So here, patient is covered here, right? So I make a less than 1 inch incision. I go with the dull end, and it is really hard. Arteries are very, very robust. They have to be. That's the whole nature is. Otherwise, we all would bleed and die. Okay, so I go with this, and I go put it on the bone. And even if there's an artery here, it pushes it to the side. The artery is not fixed, right? Once I'm in, I go with the small dilator. Now I keep the small dilator on the bone, and I take it out, change, and then I put the.
So you've sort of kind of moved it away.
Yes, by using the dull
sharp end.
Using the dull end first, then let's do it one more time in for the camera. So I use the dull end first, and even if there's the artery, push it to the side, then I put that as a fix the trajectory. I'm on the bone now, and then I use the sharp end now, which then hold the space for me. And then I hammer it barely in so that I keep that trajectory. Okay, you will see that when we are there. Okay. But that is the reason I do this technique, and that is I did it after I had that one vascular injury. Even without that, it's extremely rare that you will have the vascular injury.
What was the sequelae of the injury? Did you need a vascular surgeon to come in? And
no. Actually, in the surgery, it was no problem. Okay. In the surgery, but then patient came back with a huge pseudoaneurysm. Okay, and then I had to send the patient to coil it. Okay, so and after that, I start doing it this way. I never had a vascular injury ever since then.
What clued you off that it was just huge hematoma, like ecchymosis all into this?
Yeah, it was a huge collection, and I start draining it, and it wasn't stopping. So I just put pressure on it, and then I knew that it's something else is going on. I got a CT angiogram, and then we had a pseudoaneurysm. Now, no matter what kind of surgery you do, this is extremely important now. If you do any other system, it's irrelevant to tracking. But let's show them that. Come here, please.
What do you want?
Bring our stuff in. Some of our stuff in. Now, in any kind of surgery, which we will talk about, you start with literally putting a guide wire across the sacroiliac joint, right? That is the first. So you put a guide wire, and you use an electric drill, you put it across the sacroiliac joint. After you do that, the steps in almost every single other system is you dilate, you use a small drill, you use a big drill, you use a tab, then you put a screw, and then you repeat all those 3 steps, okay? Dilation, small drill, big drill, tab, screw, in that order. Now, there's a problem there. The step between small drill, big drill, tab, and screw, you put almost a centimeter hole from iliac crest to sacrum, and then you take it out. Then you have a 1 centimeter hole from the spongiosa of sacroiliac, sacrum, iliac crest to outside. In 1/7 to 1/10 of the case, it starts bleeding like you haven't seen that before. The only time I have seen that in the sagittal sinus bleeding, when you open it up and then it just pours blood out. The worst case I had It was a patient that I lost 700 cc, which doesn't sound much, but I lost that in 4 minutes. Okay, because it 1 centimeter hole, blood just pouring out. It thankfully it doesn't happen. It doesn't happen more than 1 in 7 to 10 case. But then what you have to be as a surgeon, you train. You just have to keep going. No matter what system you use, in 1/7 to 1/10 of the case, that will happen. Except in Trident. Why? Because in Trident, once you put this in, you don't put a
Now you're talking bleeding just from bone, just from.
spongiosa.
just
No,
being-
I'm not talking about arterial bleeding. No,
Yeah,
that's a
yeah,
different.
you're just talking about
that-
the
that is-
cancellous bone is just,
Yeah, it's a
Okay.
dark cancellous bone bleeding from the bone. No, we talked about the arterial. That we are done with that. I have never had that because I'm using the Darling. No, but in a regular system, you put it in, you put a hole in, you put a bigger hole in, you
Mhm.
tap it, you put a screw in. There are a lot of space that you take the drill out, and then you have a hole coming from the spongiosa all to the skin. In 1 to 10 cases at least, it will bleed like hell. Okay, so you have to be prepared for that. This will not happen with Trident. The reason for that is now I have some pictures. You see me. It is like I just massacred somebody on the floor. There is like and 700 cc of blood. It's not much if you suck it into the sucker, but throw 100 cc of blood on the floor.
Yeah.
See how it looked like. It looked like you massacred 5 people. Blood has the psychological effect, and if that happens in the OR, I can't tell you how the OR will behave. You suck 2 liters of blood out to sucker, nobody cares. But you throw 50 cc of blood on the floor, everybody panics. Okay, this is the nature of it. But you have to be prepared. The nurses have to trust you. But for Trident, you don't have to be worried about any of that. The reason for that is you put this in, and the Trident goes in. No small drill, no big drill, no tap. The screw is all drill, tap, and everything. And then it has no point. Is really a hole from inside to outside, and even more. Those holes of the Trident are made that they cut the bone, internalize it, and plug the hole with your own bone. They become part of the fusion. So that problem goes away. That you have that in 1 to 10 of the cases, this massive, I'm talking about massive bleeding, okay? If you use any other system, just make sure that you know it, you're prepared for it, you can move fast, and then after that, you put the ACE bandage. In one of the hospitals here I'm not approved still with the Trident, I do the old system. Yeah, okay, I do that 3 times. I do that 3 times, and it happens. Or two screw, or repeat 2 or 3 times, so it takes longer. But that's not what I'm concerned about. If my surgery is 15 minutes or 35 minutes or 40 minutes, that's not what I'm concerned about. But it starts bleeding, but then you have to be efficient and just finish it up and plug the hole with the screw, and then put biologic to pack it. So then it stops, and then you put the ACE bandage around the pelvis. We did it. Just happened yesterday.
Just yesterday now, Mary?
Just happened yesterday. Okay, so it happens in 1 in 7 to 1 in 10 cases. Okay, that problem you don't have to deal with Trident for what we just talked about. So let's go next. But there are a few things as well about Trident you have to pay attention to. We'll come back to that. So here, let's go next. Okay, this is now important for you because you're going to see them in your office. I used to say I never see sacroiliac joint. Once you start looking for them, it's like field of dream. They are everywhere. It's like the sixth sense. I see dead people everywhere. Once you start opening your eyes, you see them everywhere.
Yeah.
But these are younger patients, mostly female, especially if they gave birth within the last 2 to 5 years. The rate of sacroiliac joint is much higher. It makes sense because they have to open up the pelvis, and during pregnancy, some enzyme come and loosen those ligaments, so your body become more flexible. And then trauma, meantime trauma, and especially people who run. Young, athletic women are most prone for this sacroiliac joint. And the important thing is, I hear that a lot. In the night, the pain gets worse. And the mechanism to that is the twisting. We come back to that. The way to provoke it is the twisting of the pelvis. In the night, if you automatically, every 20 minutes, you turn from side to side. Every time they do that, it wakes them up. That's why they don't get a good night's sleep, and
they're miserable.
They're miserable in the night. To ask them, how is your sleeping? And if they say, oh, it gets so much worse in the night, that is a typical sign that it's a sacroiliac joint. So let's move through this and we talked about the statistic, and let's go to diagnostic. We talked about one of the tests that we do here during the exam is actually literally we don't do it very often, and I learned it to do that with sacroiliac joint. Just freaking ask them to stand up and put their finger where the pain is.
Finger 14 test,
And that we have a name for that. We called it 14 test. Okay, so often we just don't even. We do some exam, but we don't even ask the patient, where is the pain? Put your finger on it. And then they start putting the whole hand on it and say, no, please put your thumb. This is how I ask them. Put your thumb on where the pain fingers. And then they put this and so, no. Put your thumb, you have to sometimes tell them 3 times, because there's no ambiguity about which one is your thumb.
We find the same one.
Yeah.
The same thing, the same exact findings. Exactly what you described.
Yeah. So put your thumb where the pain is, and then they show it to you. And then the symptoms can be so variable. That is, they are way more variable than spine-related pain. And obviously provocation test. Now, these are criteria are very clear and are recommended, and Medicare asks for that. You have to have a recent CT or MRI and rule out other pathologies. But CT or MRI is to rule out other pathologies. It's not to diagnose
Help you make the diagnosis.
Okay, because diagnostic of the sacroiliac joint is not a picture diagnosis. Okay, but you have to get them to make sure that they, God forbid, they don't have a pelvic tumor or a spine problem and so on and so forth. But so you do have to get
Sometimes though, we even find they do have spine problems. We just have to counsel them. This may not be all of their back pain.
And that is
You have
very
degenerative
important.
discs,
Absolutely.
but this, you've had 2 blocks, they've worked on your SI joint, you got all the clinical symptoms, but you still need to consider that in the back of your mind. That may pop up.
And I made a huge difference when I start including sacroiliac joint in my differential diagnostic, and that is makes such a huge difference. People come. I had a patient who has a scoliosis, 88-year-old. They big place wanted to do a T5 to sacrum on an 80-year-old, a 3-day surgery, 2 years recovery. We injected the sacroiliac joint. Pain 90% went away. We repeated that the same. I just did the sacroiliac joint, a 20-minute procedure, the pain is gone. So you see that there, one doesn't rule out the other. And clinically, that is the problem, that many times we look at the picture, we make picture diagnosis, lots of this so-called link-in lieutenants, that they go, oh, what do you do? Show me the upright and so on. How is the patient doing? Where did you learn to diagnose that? Did you examine the patient? Did you let the patient put the finger over where the pain is and so on and so forth? But no, all of that goes away. Is the angle 7 degrees or 9 degrees? Okay? And if you try to fix an angle, then patient will require, an 80-year-old person will require a T4 to S1 fusion, which was she offered. She was about to be set up for that.
With a life expectancy of 3 years.
Horrible. In that age group, that kind of surgery, he knows what that life expectancy and so on is. But we did that 20-minute procedure, and she's pain-free. So, and that is what I think we should include that in our differential diagnosis. So, you remember you talked about the radiculopathy?
Yeah.
So, Mitch or Amanda will send you the references for all this, what we are offering here. Go and just read the original paper. As a matter of fact, it would be unusual not to have something that you would call it radiculopathy. And the reason for that is, you remember that at the point when the nerves are going down here, there are nerve roots. This is still not the sciatic nerve. That is why you can have individual radiculopathic pattern with sacroiliac joint right there.
Yeah.
Okay, so you mentioned it, and here it is, the
Yeah.
reference for you. Okay, now let's talk about what it looked like. You know, this is a typical presentation of the radiculopathy with the sacroiliac joint, mostly L4 and L5. I hope it makes sense to you now. Now you're understanding that these are the nerves, L4 and L5, but you cannot get L3 or S1 symptoms, okay? But typically, this is what you get, okay? So especially if patient has this kind of picture of pain distribution, then you should, just include the sacroiliac joint in your differential diagnostic. Okay, especially if they had previous lumbar fusion, you should consider that, because you remember it goes from 22 to 43%. So let's go now to 14 test. Here, use the middle finger. I asked them to use the thumb because it's less ambiguous. You don't have 4 thumbs. Well, not at least in one hand. Okay, so, but if it is within 1 inch from the point to the same place twice, then you have it already. And then all this provocation test, and all of that is, sacroiliac joint is a very stable kind of joint. It has to be. You have to use your femur or the rest of your body to amplify your force there. And to do it real, you have to get on the patient and really put hard. For that reason, that is one of the reasons surgeons don't do that. They're too busy to get in and do all of those tests. So we are working on a paper now to reduce the threshold to get there. You do what we call the combined test. If it's positive, you send the patient to physical therapy, they can do the full test for you. Okay? And one of the reasons, I hate to say that, there are 2 reasons we don't treat, 3 reasons we don't treat the sacroiliac joint properly. Number 1 is we don't know it. Number 2, unfortunately, is that it pays very little to fix it. Number 4 is getting the tests, exam, and so on is more cumbersome, timely, and so on. So we have created the so-called combined test. Do you mind to come and join me here?
Sure.
So in the combined test, actually, do you mind me to do the test on you? And then you can actually, can you take this so we can see it here?
Everyone's with you?
Yeah. So that in the combined test, I'm sitting next to the patient, and it's a combination of Gensling, Faber, and distraction. And instead of putting you on something, I have to get up and in the clinic, forget about it. You won't be able to do that. So do this. You already lots of patients say, I can't, it's so painful, I cannot do it. And then I stabilize the knee here, and I said, don't resist, don't help me, don't resist me either. Just relax. I'm going to go 3 times. Every time I'm going to push more. If it's painful, you just tell me and I stop. Sometimes already when I put my hand here, they say, no, you are not going to do that. But then I go 1, every time a little more, and I go 3 times until, we are actually writing that paper up to correlate it with the regular test and with the outcome and so on. But everybody can do that. I mean, there's no reason not to do that. And if you do that already, the pain is getting worse. For God's sake, just include the sacroiliac joint. You can save a lots of problem down the road. Lots of people that have spine problem, as we talked about, and sacroiliac joint. You go and do the spinal fusion, and they don't get better because it was sacroiliac joint to start with. Okay.
Do you still think this could be a hip pathology though?
Say one more time.
If somebody gives pain, could it be the hip as well?
Absolutely. Now, the differential diagnosis of this area is the hip, sacroiliac joint, lower lumbar spine, pelvic floor. But the way we will, at the end of the day, we do this provocation test, if 3 of the tests are positive, you have like 68, almost 70% sensitivity. And we give you a poster of this, how they are done and so, but at the end of the day, you literally put patient's weight, patient extremity to stress the sacroiliac
Sometimes I'll tell them to get in the position at night that bothers you.
You're good. That's
And
a good
then
one.
I give them a little pressure and they go, "Ah."
Yeah. Now, but at the end of the day, if that's positive, the true diagnostic is this diagnostic SI joint blocks.
Yeah.
Okay. Now, and it has to be done in a very specific way. You remember that mental picture of the articular part of the joint? The needle has to be there. You cannot give them like 20 cc because then you infiltrate everything. No matter where the pain is coming from, it's going to be gone. 2 to 3 cc max, preferably 2 cc. So 2 cc low volume in the articular part of the joint and confirmation, either with X-ray or with CT. And you have to be sure you are in the right place, and you put a little bit, and then it doesn't have to get better. Many of my patients, they come and tell me, oh, doctor, it didn't help me at all. After 3 days, pain came back even worse.
Yeah.
What does that tell you? The first 3 days, pain was gone.
Yeah.
This is positive.
Yeah.
No, and that is the idea. I always tell them, no, listen, this is not to make it better. This is to find out that you have to work with it. You have to make them understand that, because otherwise, they and don't rely on memory.
Do you do these by yourself?
Yes, I send them out, and everything that could go wrong exactly went wrong. They didn't confirm it with, with contrast. They didn't infiltrate low volume.
Yeah.
They didn't give them a pain form, so they can go and write after that. Because I tell them, like, when you go to the dentist, if he numbs it up on this side and drill on the other side, it won't work. This is what it's about, to see if that is the side that your body is drilling on. What about though if they numb it up here and you come back next day and he drills next day? Won't work. It's just about to see if while numb, 75% of the pain goes away. Take these forms, write the pain down before and after, and then we come and they say, oh, it didn't help. And then I go and look at the form. The pain went from 8 and 9 to 1, 0, 2. And then it creeps up again after 3 days.
Sometimes because we send ours out, but you think sometimes we have to send them to a second person to get the injection.
This is not a trivial injection.
I think you're absolutely right on that. You have
That's
to
why
find
I'm doing
somebody
it myself.
really reliable.
Yeah.
And sometimes the issue is though they get sent from a pain doctor, say pain doctor A, and there's a little bit of a political diplomatic thing to do to say, I'm going to send them over to pain doctor B who doesn't work with you.
Do yourself.
So
that's what I learned to do. This is something, it's such a huge impact.
Yeah.
You remember the other name the name of this presentation is the miracle joint. Because you do that surgery, people who are suicidal, they go back, they're off narcotic, they go back to work within a month or two, their life changes. A miracle joint. It is important enough. Don't be political about it. Do it yourself. Okay, it's not really, once you know how to do that, it's not really hard. When we are in the lab, I show you as well how I do it. So, and at the end of the day, but it is a hard joint to inject. It's much easier to do epidural injection and so on. It's a low risk because it's really not much vital structure there, but it's not easy because you have to maneuver between the corners
I think
of the
people
bone.
don't do them a lot. It's intimidating. I think it's like you said, a hard joint to get into.
Yeah, and you just have to do it in a very specific way. Then it becomes like anything else, become easy. So and now it used to be 3 injections, each of them giving you 75% improvement. Most of insurances, they know this works. For God's sake, this works. They have gone to 2 injections. Okay, this is one of the few things that the insurance says, go fix it. I've been spending 10 years money on this patient for all this nonsense. Go fix it. So, and they have come a long way. They had difficulty at first to get these surgeries approved. Not anymore, because it
Notice
works.
the same thing. Have you noticed that?
No,
So,
it's been.
75% is positive, 50 to 75 is meaning it's part of the problem. And then if it's less than 50%, then usually, just look for other reasons, okay? if it is between 50 and 75%, but they have a massive spondylolisthesis or massive finding in the spine, I fix the spine first. If it's more than 75% and it's like day and night, like this patient, 88-year-old, it's scoliosis. For God's sake, I'm going to fix the sacroiliac joint first. That sometimes gives them enough relief that they don't want even any other thing. And then treatment. Now, conservative therapy can help, like anything else, to certain percentages, okay? You make the pelvic muscle stronger. Braces don't really help for sacroiliac joint. They are very low. Then obviously, therapeutic sacroiliac joint injection. When I do my injection, I always put 40 milligram of Kenalog steroids in. Some of those, 1/4 of those patients, I don't see them for years. 1/3 of the patient, they are better. They decide not to have the surgery. They still come back. But that when I'm doing the injection, when the needle is there, there's no reason not to put any steroid in. And it wouldn't really mask my diagnostic part because steroid never works right away. You know why steroid never works right away? Steroid is not a medication that never works right away because first, your body has to take that steroid inside of your nucleus, modify the expression of some genes. That genes have to produce messenger RNA. They go, then they produce factors, proteins that reduce the inflammation and so on and so forth. That process takes somewhere between 3 and 7 days, in average 5 days. So it won't interfere with your diagnostic part at all. So go ahead, give some steroid because 1/4 of them for sure, after you do 3 times steroid injection, you don't even see them. They don't need surgery. Yeah. They get better.
You do a lidocaine and the Kenalog?
I do. In our protocol, we use the 0.2 Marcaine, 2 cc without epinephrine, and 40 milligram of Kenalog. So now, let's say you do need surgery. This is out. Nobody really doing this open, destabilizing the spine to do that. That is old school. I mean, even the picture looks really old because I don't believe it's really a reasonable thing anymore to do. I started with the side plugs. And that is one of the things I have problem with the industry. They did a good study with these plugs that sacroiliac joint actually helps the patient. I'm going to show you that study. But then they went to insurance and says, we have evidence that this works, but everything else doesn't. Mm-hmm. No, it is like, let me show you something. You know how unethical that is, to saying that it works. This was the study. Very powerful study by Dr. Pauly, who's part of the University of Minnesota. Literally, it was unethical to keep the people on the control group. It worked so well that to cross everybody from the control group to the therapeutic group, it works. It's a miracle. It really works. But then they used the data and said, the only way this works if you use those plugs. If you use a screw, there is no evidence that it works with a screw. Whereas we know a screw is 4.5 times stronger than a nail in any category. There are papers about that. I was a reviewer for one of the papers. Do you know what that really means? It is like literally going and saying, do you see that beautiful steakhouse? They have a juicy steak. It's good for you. It's good. But the only way to get to that steakhouse is taking that route with this car. So that is bastardization of the data. And that is so unethical at so many levels that I think people need to go to jail for that. Because lots of people didn't get their surgery approved. They were in years of pain because one company, a lobbied insurance company, said that's the only way it should be working. And it disapproved, and the insurance company disapproved any other way of doing that. Lots of people, I don't know how many people committed suicide because of that, because some of my patients are suicidal.
Oh, yeah.
That is unbelievable.
Yeah.
That is what happened in our
There
lifetime.
was a
So
lady we saw a few weeks ago, she said, I would have crawled through the snowstorm to get here if you told me you could fix this.
Yeah.
She had an infection in the joint years ago. And then fell off no, she fell off the countertop table. She was cleaning a window, smashed, and since then she hasn't really moved out of bed for a couple of years.
And do you know what is even getting better? The company who for 15 years advocated these plugs, they just came out with a screw. About 9 months ago, they came out with a screw. Yeah.
Miracles.
Yeah, they came out with a screw. So if it's really, that's the only way it's working, why do you build a screw after everybody else has built a screw? So unethical, absolutely unethical. So I started after that, and by definition, plugs are not as strong. You have revision and so on. So I went to screws. I went from small size screws to large size screws, and the result got better and better. And then we will talk about the films in when we go to the lab. And then now these days I use two techniques, two different hardwares. Both of them are screws with a large diameter inner hole. And those large diameter inner hole is because, first of all, bone grows into them and they become part of the fusion. Okay? But more importantly, both of them are used through perpendicular to the sacroiliac joint. And again, here, let's take this. In some system, you go both of them lateral to medial. You go truly lateral to medial like this. But imagine number one, a piece of the wood. I'm just a carpenter myself. I believe more that instead of fixing them this way, I believe just more in a directly perpendicular to the joint. In the true lateral to medial, because the joint is not truly lateral to medial, joint is not like that, you're putting the screw this way. But even more important, when you do it this way, this is your C-arm. The C-arm is here. The C-arm is in your way. Whereas if my C-arm is here and I'm going truly perpendicular to the joint, the C-arm is not in my way of doing surgery. Okay, it makes it technically much more easier, pleasant, and in my opinion, makes it mechanically more stable. But there's not really data that shows any different in the mechanical stability. It's just me as a carpenter, I would never put a screw in a joint obliquely. So, but both of them require you to get a true lateral view of the pelvis. Then I put my wire there and I draw the border of the sacrum on the skin. Here, you see the border of the sacrum on the skin.
I've got an old cover over there too that shows it.
Yeah. And then, we will work on that. And then I use the promontorium. So after I do anterior and posterior border, I use the promontorium to middle of the sciatic notch. So practically a line that goes from here to here on the skin. So you see 3 lines on the skin. 2 lines are the border of the sacrum. And then you know the orientation of this.
Anterior, posterior border.
Yeah. And then you promontorium to the middle of the sciatic notch. And that's practically a pelvis tilt. That's what it is. And then you have 3 lines. And then I draw here, you see that there? The lines of the sacrum, promontorium to middle of the sciatic notch. The middle of the sciatic notch and 1 inch up in the direction of the sacrum, that is my cut usually. So my cut is in the middle of the sciatic notch on the skin, 1 inch up. And that ends up
Straight vertical.
Yeah, well, I want to go in the direction of the sacrum because that is where I pivoted for my other screw. So here it is. Border of the sacrum, promontorium to the middle of sciatic notch. Here is in the X-ray is the middle of my sciatic notch. And that's my skin incision, the direction of the sacrum.
Okay, so you take that spot, just make 1 inch vertical.
Yeah, that's all they do. And then you go at the angle and then rest it on the iliac crest. Then you use the the dilator to hold the trajectory, then you put the sharp end and hammer it a little in so the tip stays in while you're going to inlet and outlet view. So once you go to the outlet view, so first I start with the, okay, here we got this skin cut, I'm going there, I'm resting in the, now if you're going to use a trident, the best point, entry point is just, imagine sacrum S1, S2, S3. When I talk about sacrum, I'm not talking about entire sacrum, I'm talking about S1, S2, S3. Imagine S1, S2, S3 is like a mass, it has a center of gravity. That center of gravity is obviously closer to S1 because S1 is more massive. And just center of gravity, you put your first, the trident screw, the other ones will orient themselves automatically. If you're going to use multiple screws and different system, put one below the sacroiliac, S1, S2, and then one at the S1, S2, and the third one just as S2. Don't try to get anything in S3. Usually there's not, bone mass is not enough for that. For trident, you just aim for the S1, S2, here, right there. And when the first screw is in, you're done. And we'll show it to you. Once the first screw is in, there's really nothing else to be done. The second and the third screw go through the same sleeve and orient themselves. It's like magic. So, but once you have, at this point, you did a skin cut, you are at the front of the sacroiliac shadow, I call it. On the iliac crest, you notch it in, and then you go to inlet view. In inlet view, you see the three become one, and then you aim for the middle of the sacrum. And then you use your electric drill and you drill in. Maybe you want to go a few times to between inlet and outlet here. Inlet into the butt, outlet about 65 to 75 degrees to the other side, depending on patient's anatomy. And here, obviously, when you have your camera, you have to pivot your guide wire along the axis of the, see, I see that too often on people who are less familiar with MIS. This is the camera, and this is the guide wire. They try to correct it, and then they go like this, or they go this way. If the camera is like this, you want to correct, you have to go this way to correct, okay? Because if you want to correct in this direction, you have to go to the other view. Mm-hmm. So in inlet and outlet view, and that is sometimes, you know, especially when you start, that is easy to make that mistake that you are like here, you are in the inlet view, and you're trying to adjust it. You want to go a little, you know, more anterior, posterior, and so on. But instead of doing that, you're going this way automatically in the anatomic direction rather than this is the direction you need to go to change the, if the camera is here. Now, in the outlet view, yeah, I have to tell my fellow multiple times, you know, it will not give you any color correction in that angle if you're not allowed. So here, you know, camera is here. Again, don't go correct here. You have to correct in this way. So here, if you have the so-called the outlet view, you want to go like this or this. If you go here or here, this camera won't show you and mislead you. But here now, imagine here, I'm getting the true AP, and we're going to go caudal. I have to go this way. And that this changes, comes this way. Okay, but you just have to have an understanding of the anatomy. Right? I mean, I don't believe you will have any problem because you do MIS all the time. It's just adjusting this to what the anatomy wants you to do. Okay, now that is actually it. Now then I'm going to go through the trident one time. So again, I tried many different things. I still use this, okay? It's a good system, but it's acrobatic. Doing this, you know, takes about 1 hour to do that. Trident, last time I did that, it took me 15 minutes and 18 minutes because I don't have to repeat the same thing 3 times. Now we should do actually, I want to now stop sharing here. I want to activate. If you don't want to be in TV, you have to move here so you don't see it. Okay, so I'm going to now show you the steps of the trident and explain why is it so much more easier, straightforward. And I think I should put that here. Do you mind to come and hold this so people can see that? And you help me with the trident. So I'm going to go through the steps. And Mitch probably knows this as much as I, about how this procedure is done. So here is, maybe I come here so you and you two people sit in the same angle. Let's see right here, I believe that everybody sees it that way, okay? So, first of all, every other sacroiliac joint system comes in sets. Those sets are somewhere between 50 and 70 pieces. This is all you need to do is trident. So very few pieces that do the entire job. So it's less to be confused about. Then you draw the shadow of the sacrum and the promontorium to the middle of the sciatic notch on the skin. So you have 3 lines. You withdraw it until you are in the middle of the sciatic notch, 1 inch incision, and then we will go with the dull end. And once you are on the iliac crest, then my assistant will give me the small dilator. The small dilator, could you come here and hold this? Sure. The small dilator, just hold this spot for me. I change to the sharp end. Once I'm in the right place, I just tap it so it stays on. Now I go to inlet view. The camera is here. Then camera is here. You remember camera is here. Now I go in this direction. Make sure I'm not going front or too much back. I work up. If I work down, I'm more likely to be in the pelvis floor. So I work up. Now I have this angle. Now I go to outlet view, the true AP view. In this angle, I go caudal or cranial. I aim preferably just a little caudal to the S1 foramen. Now I have my angle in the inlet and outlet. Now I use the electric drill. Should I use it actually?
Go for it, why not?
I use the electric drill to put my guide wire across. And I'm in the inlet and outlet view, I'm able to see how far I am. I can go pretty much to the, almost to my S1 foramen. Now, the next step after this is actually, I dilate everything. Then, this is one thing we use for this. Then, it tells me how big of a screw I'm going to use. I didn't go really deep, but this number tells you how deep. Once you are there, it tells you what kind of screw you should be using. Then this comes out. So this is what I've used. And the screw is assembled. These are the characteristics of this, and you learn it in the lab that the screw is its own drill, the dilator, its own cap, and it internalize, take the pieces of the bone as well, internalize that. And I put it usually on a position that I can do this, so it's not, and then I put it through the skin. I just do this until I'm on the bone. When I'm on the bone, and usually we have a big mallet. Here, you hold it. Here, I put that in and I tap a few times, turn a little. Tap a few times, turn a little. Engages.
Get it seated in the bone.
Yeah, and then once it engages, and I'm just not going to do that, that's all I do. And the rest is I have the trajectory and everything. Now I am all the way in the bone here. And it is made such that it really finds its way, drill, tap, and everything and so on. Once I pass the sacroiliac joint, or the tip passes the sacroiliac joint, actually the guide wire comes out. And then I finish it up with the literally sacroiliac joint, the main screw. Now, it becomes harder when you get toward the end, when the flange here hits the iliac crest, it becomes harder. Once it becomes harder, you go to inlet view. In the inlet view, first of all, you know what the direction of the sacrum is on the skin because you draw it. But then when you get the true inlet view, you see those two holes here. They superimpose on top of each other right here. And then in the inlet view. You see here is the inlet view. And those two holes on the side, they align. And then you don't see them, the parallax anymore. And then so you have two elements there. Number one element is that you have the shadow of the sacrum on the skin. And this aligns with this hole here, because the second and the third screw, they go this way and this way. And secondly, these two holes there, but you have to have a good inlet view. You have to understand the inlet view. And then you're done. Then literally, I'm going to show it the rest here. So you have aligned it. These holes are aligned in the inlet view. The next step is you use an awl, and the awl is directional. You see that there? You put the bevel tip toward your sleeve, because when you go out, it tries to center you toward the same screw. You awl here, same here. You put it here, and you go just an inch. You don't have to go more than an inch. Okay, so you tap it in, then you're done. And then the next step is it's in the direction here. You go in, you put the first screw, you lock it in, you pull it back, you take it out, and you do the same for the other side. Once you're done, you just turn it around and remove it, and that's what stays in. So because you don't have to repeat the other steps 3 times, you do it only once, and that's usually, the average, it takes us 15 to 20 minutes to do that, rather than an hour, because then you have to, if you are going to repeat that, you have to go again to lateral, you start all the steps again from the start and so on. And there are few things you need to know. First of all, one of the things is that we learned it as well. We just brought it up all the year ago. It's FDA approved and everything, but what we learned is that some people have really hard bone. When you put it in, I put it in now, and sometimes I use a bigger hammer, and really sometimes you have to hammer it in. And most of people, it's not a problem. You just put it in, hammer it a little, and then in some people you have to use a big hammer. And this device here, where does that thing go?
Really important.
Yeah, here. You put the screw in, you put the handle in, you put it on, and you really have to hit it hard until it engages. Okay. Then, as well, in the same people, you have to make sure you make a nice hole in the pelvic, and especially the one that goes caudal. The angle is very unfavorable. You have to be careful. You put it the correct way, that you literally aim it like this, so it bring it closer to each other. So you see that there, this is the difference between this and this. Here, the screw is here. You put this next, the bevel part next to the sleeve. By the time you go out here, it brings the trajectory of the screw closer to your main screw. So not this way, and go 1 inch truly in the bone, so the screw doesn't have to struggle to start on the skin. Because if the screw have to struggle, it may slip here, and it will increase this angle, and that's a bad thing. If this disconnect is going to be a problem. Now, another thing is that when you put the other screw in, these screws are made in a way that you cannot lose them just like that. You see, the way it is that, it's the thread inside, you put it in, you thread, and then you put it in. So if you lose it, you still can pull it out. But those things are very fine. If you start hammering on those, you are just going to destroy them. And the worst thing that can happen is that literally you lose it halfway between with the wrong angle. That can become difficult. You don't have to deal with that if you truly follow the steps as we just discussed. You put that in, you put it next, that these steps are extremely important. You put it with the bevel toward the thing, because when it comes out, it brings the screw closer to the main screw like this. Other side, another side, it has to be obviously the opposite way. And then once you have done that, you put it in, you make sure that you don't have to fight it, that it goes start easy because you already made a hole. Then you go in, and every few turn, like 2-3 turn, you tap it just a touch so that this still is, you make sure it's engaged, not halfway engaged, it's completely engaged. Otherwise, you're going to, again, destroy those fine threads here. So every few turns, you just tap it a little. And then once you are all the way in, there's a certain special feature here, is that the head of this and head of this are a little oval, a fraction of a millimeter, like 0.25 millimeter. And you turn it until it's really hard, then you turn another quarter of a turn, then they lock. And that is why these three are much stronger than 3 regular screws, because they can't send their load to each other. So 3 of them are much stronger than 3 separately placed. But so practically though, you go in all the way in. Once it's really hard, you put another quarter of a turn. Okay. Once you do that, they are locked. If you don't feel that, see that here, try to disconnect that. It won't, because it's not all the way in, because I didn't lock it. Okay. Now I talked to you in the thing how you can troubleshoot that and so on, but because I put it in but I didn't lock it, the space is not open for that to turn back. But if I go a little deeper, then it becomes easier. Okay, here it's not a problem, but see how they connect? That screw has to be, you see that there is a little that's still out there. Do you see that there?
Yeah.
If I would have made that quarter of a turn, that would have sunken in, then I know, first of all, feeling. Many of the things that good surgeons do by feeling. Okay, so I feel it's hard, I go another quarter turn, then I'm sure that's not going to be a problem. And then at the end of the surgery, obviously, once I'm done with all of that, I have put my screws, everything in. Here, I put my both screws in. My assistant has filled it with biologic. If I wish to do that, I put it in, I put my biologic in, and then I turn it around, I remove it, and that stays in. Okay, well, and all of that to do the surgery, it's not a full set. It is this, and when this is assembled, obviously, that is assembled in a very specific way. So it's assembled in a very specific way, and this is all you need to do the surgery. Okay, as a matter of fact, you don't even need 2 of that. One of that is enough. Okay. And if you don't want to put biologic in, because you already have stuff in, you don't have to, but I always do. You don't even need that. So this is all you need to do the trident. Now, to take it out for whatever reason, there is a special sleeve. One of the things that people can make the mistake is they put it on with the removal sleeve. You see that here says trident introducer sleeve.
Yeah.
And it's even my people sometimes, instead of that, they put it on, it says removal sleeve. Yeah. The difference between the removal and the introducer sleeve is that, you see, when I put the regular sleeve, when I turn this, the main screw turns and the sleeve turns with it, because the sleeve and this, they lock to each other. So to take it out, let's take it out. Let me show. Imagine, come here, please. Imagine this is in the patient, it's too long, it's whatever reason it is, you want to take it out. The first thing I do, the same way, I take this, The same way, I go with this inside of the screw, hold it, you hold it there. Then I go with the dilator inside. If I come a few weeks later, obviously I dilate again big time. Now, at this point, I have the whole thing, prepared for me. And this comes out. The next step is, can you put this as well? The next step is, you see that there? This goes in, and I fit it inside of that hole. The regular sleeve, it wouldn't fit there, it wouldn't go through. But the remover sleeve, it goes through, but it wouldn't lock. It shouldn't lock, because if it would lock, I cannot engage it. Now I go and engage it. Here, now I engage it. Once they are engaged together, this can come out. This goes in now. First turn, then engage. Take it out, and then because of that mechanism, it won't fall apart. Once I'm through the thing, it just comes out. Now, I can put back this, and then take the screw out. And because of the way how this locks to that, it won't disconnect while I'm taking it out. But if they put it in as a first one to put it in, they turn this, but this doesn't turn, and then they disconnect. So before you put it in, make sure that they didn't do the most trivial mistake, put a removal, they give you the screw with the removal set, because they look identical, and I asked them to change the color, they eventually will. But I think that is good enough, but you would be surprised sometimes. So pay attention to that they don't give it to you with the removal thing. One of the other things is, just you have to know the screw and make sure that this is properly engaged and so on, and that there's not a gap between and so on. All of that shouldn't be a problem, but everything that can go wrong is human. They're going to give it in a different way. And let's say they don't do any of these mistakes. I have done this surgery in 12 minutes, skin to skin. 12 minutes is skin to skin, meaning including closing the skin. And I have done this surgery in 22 minutes, but I don't have done any surgery longer than 22 minutes for this. The longest surgery I have done with the Trident was 22 minutes. But there are some other things, subtleties that you will discover when you are doing it, especially, some people have truly very hard bone. Then when I get to the sacroiliac joint, I tap it a few more times there and so on. But these are things that if you're a surgeon, you just deal with it. So I have told you everything I know. If you have any question, I can answer. Otherwise, let's go to the lab. Any question? Okay, thank you. That was actually fun. Okay, so let's see. Okay. If you guys have any questions, just write your questions in our comment section. Amanda and the Ice Life people will come back to you. So we are going to end this. I hope you guys enjoyed that, and there will be a record of that on YouTube.